You're welcome to my channel. Today I'll be addressing resistant hypertension, just as the name is. Before you can make the diagnosis of resistant hypertension, you need to state categorically what the BP goal or goals are in this patient or in these patients. In diabetic mellitus patients, we expect the blood pressure to be less than 130 over 80 millimeters of mercury. But in anyone that's about to take thrombolytic agent and the blood pressure is high, we expect the blood pressure to be corrected at least 180 over 110 millimeters of mercury. The age group target could be 90 over 50 to 120 over 80 millimeters of mercury for adolescents, and 110 over 70 to 140 over 90 millimeters of mercury for the middle age. And for most patients, older than the adolescents, we expect the blood pressure to be less than 140 over 80 millimeters of mercury. Now, resistant hypertension will be diagnosed when there's hypertension already diagnosed in this patient, right? And he or she is already on treatment, in addition to lifestyle modification in place. Then the target blood pressure is already set, but something is wrong. You are unable to reach the target blood pressure already set despite all the interventions. And if this is secondary hypertension, you have addressed the primary cause, yet you are not getting the goal. You are not getting the blood pressure under control. The BP has remained high and is still concerning. This is very common in those with hypertension and other comorbidity or morbidities, like renal problems or endocrine problems not yet addressed. And this is also common among the elderly patients. But remember, there is pseudo-resistant high blood pressure. This means from the name pseudo, it is not really resistant, but because there are other factors affecting the value of the blood pressure. Let me go further on that. There is an entity known as clinical inertia. That is when medications are inappropriately prescribed, like the doctor has prescribed a good medication but suboptimal dosage, or sometimes incorrect medications are selected and the overall outcome is below the expected goal. And under pseudo-resistant hypertension, the problem might be that you've selected the right medications, the patients are taking them with the right dosages, but there are other confounding factors like over-the-counter medications. Imagine someone taking pseudoephedrine and hypertensive patient on correct medication. You keep checking the blood pressure, but it's not within the range you expect. And of course, inadequate lifestyle changes, like I have seen some situations where the patient has agreed with you that, okay, I will reduce salt intake, but on getting home, he or she will not comply with that. Be adding salt to the food just as if there is no high blood pressure. All the above are raising the BP and making the treatment to appear to be ineffective. Hence, the blood pressure will remain high. Reflect on some possible causes. In other words, reflect on what could be responsible for you not getting that blood pressure controlled, or for you not getting the set target. Is this a correct diagnosis? We have to measure the BP over and over again and measure the BP correctly. You can check my channel for BP measurement already published here. You can use ambulatory blood pressure measurement, and you can ask yourself, could this be white coat hypertension? Meaning, when the patient is before me, the BP is high. When he or she is out playing on the field or resting at home, the BP is within normal range. Well, 24-hour ambulatory blood pressure measurement will help you. Still reflecting on possible cause or causes, we will ask ourselves this question: have I done enough as per the treatment? Have I selected the correct antihypertensive agent in this patient? For example, a patient with secondary hypertension and pheochromocytoma. Am I using phentolamine? Is this a white patient? Am I using AC inhibitor and beta blockers? If it's a black patient, am I using dihydropyridine, calcium channel blockers, and diuretics? If this patient has cocaine, have I made the mistake of using beta blockers because I shouldn't be using beta blockers in this patient? And am I using non-dihydropyridine calcium channel blocker because that is what I should use in this patient with cocaine? So you can check my channel for a separate presentation on no beta blockers with cocaine. Because if you are using beta blockers in an individual who has ingested cocaine, you are not going to get that blood pressure down. No. Still reflecting on possible causes, is there any new medical problem not yet diagnosed that I don't even know of? And is there increased sympathetic stimulation, particularly at the time that this BP is being measured? Any fear, panic attack, stress, stimulants, cocaine, like I said in the previous slide. Still reflecting on the possible causes, if it is secondary hypertension, is the primary cause already addressed? Because without that, we are not going to get out of the problem. And okay, you've selected correct antihypertensive, right, based on the definitive diagnosis, correct. But am I using maximum dosage yet? If I'm not winning, can I increase the dose to the maximum dosage? Am I using multiple medications, like 3 to 4 different ones, with one of them being a diuretic agent? And because people are listening to my presentations all over the world, because I learned we have covered about 107 or 108 different countries already. Thanks to you too for that. So could this be fake drugs in your country? Could this be fake drugs? Okay. Still reflecting on possible causes, how about compliance on the part of the patient? Because you prescribe the correct ones, you've at the correct dosage, but the patient is not taking the medication as expected. How about the lifestyle modification? Has it been properly followed? How about cognitive impairment? Because the patient has forgotten to take some of these medications, right? Is this patient depressed? What is the financial status here? I know, is it that this patient cannot afford these medications? Can I reach the pharmacist supplying this medication and get info about refilling? How often he or she comes around to get that? And is there a history of abuse in this patient whereby the caregiver is not giving this patient the medication at the right time. Still reflecting on possible causes, we have to review the risk factors. Okay, obese patient, weight is not lost yet. Diabetic mellitus, that is not controlled. Lipid is still all high, particularly low density lipoprotein or very low density lipoprotein, still high, when we expect high density lipoprotein to be the one that will be high. Are they still taking salt as if nothing is happening? How about smoking and alcohol? How about sedentary lifestyle? So exercise has not changed, not been increased, particularly aerobic exercise. Still on possible causes that we have to reflect upon. Any sleep apnea here? Maybe there was none before. Now he or she is having sleep apnea. How about hyperaldosteronism, Cushing syndrome, pheochromocytoma, coarctation of aorta, renal artery stenosis, hyperparathyroidism or hyperthyroidism, hypernatremia, and of course, strong family history that, oh, this is happening in their lineage. Now, what will be the effects of resistant hypertension? Meaning, there is high blood pressure, medications prescribed, lifestyle modification advice, we are not winning. What could that lead to? There will be increased morbidity, a likelihood of stroke very soon, ischemic heart disease will be on the increase, the heart will start failing in case of hypertensive heart failure, the kidney might shut down, renal failure, and of course, the life could end death. Okay, we don't want the previous slide to be part of the history, right? We don't want death, we don't want all those organs to fail, no more morbidity, and so on. Okay, we need to intervene right now. We must look for the cause, please, by all means, and address that squarely. We have to review the lifestyle. We have to go over all medications in these patients, over the counter, street drugs, or prescription drugs, history of alcohol. If you are suspicious, but the history of alcohol is not so clear, do your GGT. Smoking cigarette, which must stop. Now finally, on intervention, we have to review the antihypertensive agents to be sure we've chosen the correct ones. And do we need to add more or even change some of them? Or do we need to increase the dose or dosages? Let's find out. Discuss with the pharmacist in case you are concerned about either the synergistic effect or the worsening of side effects, particularly when it comes to drug-drug interaction. And better still, when we've done all and we're not winning, refer to the appropriate specialist. And with that, I've come to the end of this short presentation. The goal is to have that blood pressure under control. If you are not winning, take appropriate actions. Thanks for listening. Remember to share. Remember to subscribe. I appreciate it.